Okay, so hello everyone and welcome to BrainMap. This seminar series is co-sponsored by the P41 funded Center for Mesoscale Mapping, housed in the Martinos Center. It's my great pleasure to introduce our speaker today, Dr. Greg Stanisz. Dr. Stanisz obtained his Ph.D. in physics at the Jagiellonian University in Krakow, Poland in 1990. And since 1991, he has been working at the Sunnybrook Research Institute, where he is currently a senior scientist. He's also a professor at the Department of Medical Biophysics at the University of Toronto and Canada Research Chair in Cancer Imaging. His research is in the area of MRI, especially in the field of quantitative MRI, and is the author of over 150 scientific papers, which provide basic understanding of the MRI contact mechanism in tissues, such as MT, relaxometry, CEST, and diffusion. He uses quantitative MRI in the context of cancer and neuroscience, both in patients and in animal models of disease. I would just like to remind the audience to please address any question you have using the Q&A box or raise your hand. Dr. Stanisz, thank you very much for coming here today. The virtual stage is all yours.
Thank you very much for having me there, at least on your computers, that is. And it's a pleasure and honor to give a talk and share some results of our research that we have done in the past 10 or 15 years. The title of my talk is Metabolic and Structural MRI for Therapy Guidance and Assessing Treatment Response in Brain Tumors. And there is a reason why I put metabolic and structural in quotation marks, because although we do probe metabolism and some changes in microstructure, we are still quite far from understanding what we really do measure. And it would be quite helpful if we did. But first of all, let me explain to you why we need yet another methods like saturation transfer in MRI. We have a plethora of different contrast mechanisms, T1, T2 relaxation, proton density, diffusion weighted, perfusion weighted, ASL, and so forth, which most of the time provide an excellent tool to see soft tissues and soft tissue contrast. And on your left, you see images of the spinal cord, muscles and cartilage. Lower is the liver, heart, and finally brain. And we all know that MRI is non-invasive, can image tissue at any angle and position, and doesn't have any harm of radiation. There are, however, some limitations to MRI, and most of them, MRI takes time, so there are a lot of motion artifacts. Some people may argue that it's still poor resolution, sub-millimeter is the best we can do. And quite often we do not have a very good contrast, and this is especially true or sometimes true in diseases that are with not clear pathology, like, for example, in the brain. Or even tumors as well. But I think the most important drawback of MRI, standard MRI, that is, it's its lack of specificity. We see abnormalities quite well, but we sometimes do not know what's going on in the tissue. And this is increasing interesting question, because we would like to move from using MRI as a tool to localize the pathology for later surgery and so on, to use MRI as either the image-guided therapy or to improve our diagnostic tools, which is to be more specific about the character of the disease itself and monitor the treatment. And I will show you just an example of brain metastases in two patients. At the top, you have both of them actually are lung metastases. At the top, you have the patients that have a tumor in her brain, and it's responding to radiation. Those patients are treated with single dose of radiation, usually around fractionated dose between 3 to 5, but it's really single dose. And the only way, this is gadolinium, a weighted image, as you can see over here. And the only way to actually assess the effect of therapy or efficacy of therapy that we have in clinic right now is to wait until the tumor shrinks. And this is what you see on the right. The tumor is smaller in responder. In non-responder, what happens, you can wait weeks or even months, and then the tumor actually may start growing. So now you have a lost window of opportunity here, because you basically wait not knowing whether the treatment worked, whether you missed the target, or whether something else is going on. And it's especially important in the tumors in which we use radiation or chemotherapy to shrink the tumor before the surgery, like, for example, in locally advanced breast cancer. And that window of few months or a few weeks, depending on the patient, is the window of missed opportunity in which we can switch the treatment to something that may actually work. So I said it would be nice to know, to predict the response even before the treatment, and to have the tools that even before starting radiation, to have an answer whether the tumors will be responding or not. Monitoring response early and figuring there are changes may also be quite useful. And I will also talk about identifying tissue state, which quite often what we do have is we cannot distinguish between necrosis caused by inflammation caused by radiation treatment versus tumor progression. They look at the post-gadolinium the same. So we know that the standard MRI cannot really answer those questions. There are some techniques that are probing to do it, like perfusion, diffusion, but they are not necessarily that accurate and they are not reliable. So in our lab, we are thinking for this for quite a while. And one observation that we made that a lot of structural changes are happening after metabolic changes that are occurring. So maybe metabolism or measuring tissue metabolism is an answer, like measuring apoptotic response to radiation treatment. Obviously, if we are looking at metabolism, the first technique that comes to mind is magnetic resonance spectroscopy or magnetic resonance spectroscopy imaging. We know that this is great because it's specific to metabolic target. On the left, you see the lesion of the brain that depraved of NAA. This is the lack of neuronal activity. Increase in choline, which you likely see. Creatine as a marker, as a standard marker, is unchanged. And you also have increase in lactate, which indicates aggressive tumor in this type. The problem is that obviously for those of you who did spectroscopy, it's very tricky to do imaging. It has a poor resolution and you need a very high concentrations of metabolites. And on the top of it, unfortunately, because of the poor resolution, even if we do imaging, we also do have poor reproducibility related to the fact that tumors are quite heterogeneous and slight shift in the voxel may change the spectrum, unfortunately. So what else can we have? In 2003, Peter van Zyl, whom probably everybody knows, came with the idea of spectroscopy experiment in which we can boost sensitivity at the cost of specificity. And this is called chemical exchange saturation transfer, which is one of many effects associated with saturation transfer MRI. So what CEST really is just measuring indirectly the effect of exchange between water, those are the small molecules on the right, and their interaction with the slightly larger molecules, proteins in that particular case. This is a case of serotonin. And you basically have your imaging sequence. The only thing you need to do is you need to apply the saturation pulse between your imaging sequence. And this saturation pulse is usually off resonance. Those protons have chemical shift. So they resonate in slightly different resonance than the water. And then if you do that, you saturate this pole and observe what's happening. And then what you simply measure is your signal as a function of offset frequency. If you don't have CEST, this is a signal for water. If you saturate on resonance, you dump all the signal of water, you have a 0. If you are off resonance, quite far, you are not doing anything, so the signal is equal to 1. Now, what happens if we, however, do have an exchange? It's just a little movie showing what happens during the saturation pulse. What you can see, you have a chemical exchange between protons associated with proteins and water protons, and you observe a certain dip in the water signal. And this is related to the fact that those protons that exchange, water protons that exchange, lost their magnetization in addition to saturation effect. It is sometimes called the tuple exchange model, and you can model this process as well. Now, it's a very similar to spectroscopy in that sense that spectroscopy experiment, if you still have solid and water, and if you do have MRS on them, you have a small peak associated with its resonance frequency of solid and the resonance frequency of water. If you saturate them, then you obviously saturate this small little peak, but you are also, and this peak will disappear, but you also have an additional loss of water pool, and you have a Z spectrum. So what's the catch? The catch is that, yes, we do have increased sensitivity because for every proton associated with molecule, we have many water protons that can exchange. So we can increase our sensitivity 10-fold, 100-fold, and so on. The catch is that we are losing the specificity to metabolites or molecules. We can only talk about certain effects of groups like amide, amine, hydroxyl, aliphatic, and so on, which have a very specific chemical shift, and therefore they can be identified on the Z spectrum related to their position. Now, there is not the only microscopic mechanism that you have, and I'm mentioning this because I will spend the rest of my talk talking about CEST and magnetization transfer. But you are probably all familiar with intramolecular dipolar transfer. This is the exchange they give us, dipolar exchange that give us the T2 relaxation. CEST I already introduced to you. Magnetization transfer is an intermolecular dipolar transfer with it's a dipolar exchange between water protons and protons associated with very long molecules. And I will tell you in a moment how they are different between CEST and MT. And finally, you have a very complex nuclear Oberhauser effect in which the exchange is very complex, and it goes to this cascade of different molecules, different groups. Regardless of whatever you are doing in a saturation transfer experiment, you always have all those four mechanisms that are competing with each other. In a nutshell, CEST is a chemical exchange, and it's sensitive to different groups, like I mentioned it before. It has a chemical shift, and it's associated with small mobile proteins. Physical exchange, we reserve this term for a magnetization transfer for the physical exchange or dipolar exchange related to OH groups, and it's basically related to lipid vesicles and membranes and myelin and such. There are more differences. CEST is a small mobile molecule. T2 is in order of milliseconds. Exchange is relatively very fast. Pool is very small. MT, that's the large immobile molecule. Therefore, the T2 relaxation is in order of microseconds. Therefore, the line shape of this pool is very, very broad. And this is why we sometimes can distinguish between the two. And usually what we do is we perform those experiments in two different regimes. CEST regime is a regime of the low saturation power and low offset frequency. This is where the most action is, unless you have a para-CEST contrast agents, which has it shifted, a chemical shifted quite substantially. And on the left, the solid line still includes the direct effect. This is the dotted line, and also the MT that always is present in CEST experiment. MT regime is the one that you have a very large offset frequency. That's what action happens, and also very large saturation pulse. And if you see the movie, that's how the situation changes. Just look that initially we see those peak components quite well, CEST components, but if we do increase the power, this peak is not longer well defined, and we are dealing with empty effect as well. So how does it look? When we first look at that about 10 years ago, Kim Desmond did this experiment in animal tumors. The CESS spectrum of the animal tumors in tumor xenografts is very complex. The data points are actually the Z spectrum zoomed out for the region of interest in terms of the signal. And this spectrum actually consists of maxillation transfer, which in that particular component, which in this particular case, it's relatively very flat. Direct effect, this is effect of saturation on the water. And then you have different chemical groups that contribute to that. We can analyze this in many, many ways, and I don't have time to tell you which one is better versus the other. At the end of the day, I don't think it matters that much. Other to tell you that the CEST provides a very interesting contrast mechanism. First of all, this is the Lewis-Lung cancer carcinoma cell line, very fast, very aggressive cancer in mice, grows rapidly. This is 3 days, and it's already have almost 1 centimeter in the size, and it has a huge aliphatic or NOE effect and amine, and also amide as well. You can also obviously do diffusion and other things as well. But note that you don't have any necrosis in this particular case, which would be indicated by the tunnel staining brown over there. Now, less aggressive and necrotic, however, breast cancer xenografts behave slightly differently. They are very heterogeneous in their CEST structure. They have this rim that is very similar to gadolinium, for example. Contrast ADC and T1 and T2 are not that specific. And all those CEST basically reflect the fact that there are lower CEST in the areas of tissue necrosis, which is indicated by the matched tunnel staining and H&E staining as well. And that brought us to the idea that maybe we should use it to probe necrosis versus active tumor, or even monitor the tumors if we induce necrosis in the tumors by the virtue of chemotherapy or radiation. Just to mention that only CESS can let us to actually distinguish between the regions that are tumor versus necrotic, and all the other characteristics could not. And also the CEST really relate to the apoptotic index as well. We also can do a lot of things based on CEST, and this is busy signal. I'm not going to spend a lot of time in it, other than to say that once we have the CEST signal and a couple of others, we can do an automatic segmentation. And the red indicates the necrosis, and the blue indicates the active tumor. You also have the muscle as well. But that allows us to actually analyze the CEST signal depending on its environment in the very heterogeneous tumor as well. And that kind of a signal depends on the tumor type. Those are 2 prostate xenografts. One of them is 22 RV1s. Those are the less aggressive, more aggressive tumors. They grow rapidly, and there is a change in their CEST characteristics versus DU-145. And there is also obviously difference between necrosis as well. Pushing it a little bit further, we had the cell lines which are actually radio-resistant. And if you introduce them into the animal and they grow the tumor, then you also observe that those tumors have a different CEST effect. Actually, in the radiation-resistant tumors, the CEST effect is smaller, and it makes sense because the tumor is responding to the radiation treatment if it's active, not in a sort of metabolic lower state. So we are encouraged by these results, and we jumped about 5-6 years ago into the patients. And the first ones that we focused on were patients with brain metastases. And I'm showing you the two examples, patients that is responder on the left and patient who is not responding on the right. And typically what you would do is you will have an MRI done, gadolinium pre-treatment, and then monitoring treatment 1 week post, and then 1 month or several months after. On the right here we have assessed. In that particular case, we are looking at amide, but all the other assessed characteristics will do the trick as well. Is you notice this tumor initially have a very low CEST effect in its center, and that reflects the necrosis. But 1 week post the treatment, and it's successful treatment because the tumor shrunk after 1 month, almost all the tumor is necrotic. Whereas in the case of the patients who did not respond, the CEST either stays the same or it actually increases. And as a matter of fact, this treatment has been unsuccessful. In other way, we can 1 week, and we can push it a little bit even sooner, we can tell what would happen in 1 month later. And this is exemplified over here, in which we plot the change of the CEST effect that happened within the week versus the change that happened in the tumor volume in about a month. So there's a correlation between how much this CEST effect increases and how much the tumor will shrink, and vice versa. Moreover, interestingly, we can also look at prediction, and this is just looking at only CEST parameter, and it's linked to prognosis later months as well. Interestingly, it happens not only in the tumor, but also in normal pink white matter, and I will come back to this particular case later on in my talk. Probably the largest problem with those patients is recognizing or differentiating between progression and pseudo-progression. What are they? So if you have a patient with a brain metastasis and you treat it with stereotactic radiosurgery, about 70 to 80% of the patients will respond to treatment. And the tumor is sort of under control. In about 20% of them, we have a situation in which something else happens. And this is just of one of our most frustrating examples of the patient that came, he had an MRI pre-treatment. Then 3 months after treatment, you see this tumor still exists on the right-hand side. 4 months, it's still there. 8 months, it still didn't shrink. 9 months, and only after about a year, the tumor shrunk. So it's a very, very long time, and it's frustrating for the patient, and it's difficult for the Asian oncologist. Why it does matter? In this particular case, it is actually tumor necrosis, but happening very, very late. But sometimes this picture happens when you have pseudo-progression, which is inflammation, and inflammation also will eat the gadolinium and will up, and you will see this contrast as well. And this is the dilemma that you have. Those tumors, either they are inflamed or they are progressing, look virtually the same. Yes, you can do spectroscopy. Yes, you can do perfusion. But at least in our hands, we weren't that successful as long as we started using CEST, and that's what we did. This is right now 2 examples of non-responder versus responder. In other words, tumor progressing, and you still see necrotic core, but the tumor is still active. This black region is just the rim of the tumor defined by gadolinium. And you can see that in responders, this is basically necrotic core. Also, as I did tell you previously, those ones look exactly the same on the gadolinium, post-gadolinium image. So far, we have done over 150 patients. I'm not showing you all of them, but the distinction is quite good in a sense of distinguishing between those 2 groups. Tumor progression and radiation necrosis. It basically has a lower, consistently lower CEST effect. There are some issues related to the tumor heterogeneity. There's a lot of things to be done to make this a little bit more robust, but I think in the future we may have something that will solve this problem. And accuracy, at least at the latest, is about 87% in terms of specificity, but it's only looking at a single CEST component, and if you combine certain metrics, we can reach about 90 to 93%. So how does it CEST looks in a more complex tumors like gliomas, for example? Now, let me come back to this picture, because gliomas really, we learned our lessons very hard. And what I'm about to show you is how important it is to ask interesting questions. But when we started doing gliomas, after doing brain metastasis, we still weren't very happy about how we analyzed the CEST spectrum, fitting Lorentzian, or even looking at the myelinization transfer ratio, which is just the difference between one and the signal that you measure. And at that time, a lot of people were using myelinization transfer, and basically you can do myelinization transfer and deduct this myelinization transfer from the Z spectrum to seize out the CEST component. We have done this as well. So a few words about myelinization transfer. This is just the model that we are using, tuple model suggested by Bryant. You basically have macromolecules or lipids with their own T2 and T1 characteristics, and there is exchange coming here. You do the saturation, you saturate macromolecular pore, you also saturate the water a little bit, and then, since this is not equilibrium, you lose the additional signal in water, hence the empty effect. It has been analyzed 30 years ago by many people. The block equations are relatively straightforward. Mark Henkelman was the first to actually do it successfully in agar. I am pointing you out to MMT because it is a very effective way, especially in multiple sclerosis, because it does give us a contrast that informs us about myelin content in white matter very specifically. And we have those great maps that we can actually relate directly to myelin content. And since we are in the brain, we have to consider this as well. So what we are doing right now, we are collecting our CEST spectrum, which has amide and amine and also RNOE components in it, but it has MT as well. We collect MT data. We then fit the MT data to the model, from which we can then extrapolate the Z spectrum MT only. Again, you can tease out the CEST effect, and we can plot out either the maps, parametric map associated with MT or associated with CEST. MT informs you about the microstructure, CEST about metabolism. So how does it look in high-grade gliomas CEST? It's interesting that, first of all, it replicates quite well flare and post-gadolinium contrast to some extent. Interestingly, what you see are those all red regions. Those are the white matter. White matter has a lot of CEST, and it's metabolically very active. It also has a very high MT. So you have additional contrast, but also interestingly, you have interesting contrast on MT as well. And once again, you can appreciate the fact that you can see white matter and the region, those are the green ones, or edema, and the region of blue, which are associated with tumor itself. Tumors do not have a lot of MT. However, they still have much less MT than white matter and so on. And if I compare those two, which one is actually more successful in predicting the outcome? We just looked at the patients who had daily dose already, whole brain irradiation from 70 days. And we look at the change in either MT or in myelinization transfer characteristics. And in both cases, we can about 2 weeks after identify progressors versus non-progressors, basically deciding whether the treatment will be successful very, very sooner than anything else. What you use is a matter of preference. MT is basically less noisy. It's easier to use, and we currently are using it even at 1.5 Tesla on MR Linux system. But it's not the end of the story. What we did observe, it's something else as well, because we are a quantitative people and we wanted to also compare. Those, by the way, it's a lesion of cavity over here. The tumor is only at the very brink of the brain here. But that's what's interesting here is that when you compare the quantitative parameters of MT, we see the region that it's abnormal in terms of their MT characteristics. You see it as green over here. I think those are the arrows there as well. There are 3 locations that it actually does happen. On a normal post-GAD on T2 flare, you barely maybe see one of those. So this is what those regions are. We postulate that probably those are the regions of abnormal white matter and maybe infiltrating tumors. But interestingly, we also do see that in about 50% of the patients, the quantitative MT is much different than in the normal controls. Basically, MT is for the normal appearing white matter, even in contralateral or ipsilateral hemisphere, the CEST effects and the MT effects are smaller or changing, indicating that normal appearing white matter in patients with brain tumors is by no means normal. We pushed it even a little bit harder. We started to look and screen the patient with low-grade gliomas. So typically those patients are basically watched for a period of time until the progression to the higher grade occurs. So usually they are 3 image every 6 to 8 weeks with gadolinium, and this is what happens. And this is a patient which we watched, and we wanted to basically characterize and finding out whether there's any CEST characteristics that will allowed us to predict the outcome or progression to the higher grade. And we haven't done those experiments yet, but in this particular patients, what you see is abnormal empty characteristics of white matter near ventricles, as seen by those 2 regions. It's not seen on post-GAD, it's not seen on flare. That was quite interesting. And then the patients came back 11 months follow-up. And then what you can see that those abnormalities do change on flare, indicating that the tumor progressed. And indeed, as I learned, that's about, right now the patient is about 17 months after follow-up, the tumor progressed to the higher grade. So it's an interesting observation. Gliomas are diffuse in nature. They conquer almost all the brain. If we are correct that looking at MT of normal appearing white matter and its infiltration may tell us something about what will happen in the future. We also started doing segmentation because, quite frankly, you have a very similar contrast mechanism as you do post-GAD, and we are using for that MT and CEST, and this is just a portion of the tumor using, and you can do the segmentation, and we are now comparing the segmentation between what we can do with gadolinium versus what we can do with saturation transfer alone. And the idea behind this is twofold. First of all, to get rid of gadolinium altogether if it's not needed, especially for low-grade glioma patients. Injecting gadolinium every couple of months is not healthy to your brain. And the second is, however, a more interesting story that says does not necessarily reproduce all the characteristics features, is a different contrast, and maybe it can tell us a little bit more about especially surrounding white matter in the brain. And now, since I am almost done, for something completely different. CEST initially have been used for stroke. It is right now widely used in gliomas and low-grade gliomas as well to identify the type. There are many studies that are trying to tease it out. We have smaller activity in other area of science or neuroscience, and this is related to stress and microbiome intervention in stress. And what we observed is also very interesting. So usually when you have people with bipolar disorders, there's a lot of brain diseases that are not necessarily have a telltale sign of changes in microstructure. Metabolism does change. So typically MRS is very good in it, in a sense that you either have decrease in NAA or especially disturb GABA cycle, which is basically decreasing either GABA, glutamate, or glutamine. And this is exactly what happens in rats when they undergo the stress. GABA and glutamate and also creatine are going down with the stress. But we can use CEST as well to reflect those changes, identifying which component of, whether it's GABA or glutamate or something else responsible for this change, is yet another story. But as a quick experiment to just image and find out that there are changes mostly associated with the cortex in the rat and a little bit obviously hippocampus as well, it's a very quick experiment to do, and to monitor the treatment, which we are currently doing, is also very, very useful. And also you use specificity of the spectroscopy, you lose this, you gain this sensitivity and imaging of the CEST. And also we pushed it a little bit more farther. This is a holy grail of the psychiatry. It's looking at the molecule called serotonin, happy molecule, for which a lot of drugs for depression and bipolar disorders are attacking this pathway. The serotonin itself has a very small concentration in the brain, so you cannot really see it spectroscopically, and it also has a lot of molecules that are very similar in structure. We did first the study in vitro to basically show that serotonin, which is seen in green, has the CEST effect at 5.5, which is what we expected. We cannot distinguish them between tryptophan and HPT, but however, we can say something about serotonin pathway this way. And we tested this this hypothesis in rats that were undergoing serotonin stress. They basically have injected tryptophan and inhibitors to increase their serotonin levels in the brain. This is the experiments that we did a few years ago. The CEST significantly increased in the cortex in the animals that are undergoing this treatment. Whether we can use it in humans remains to be seen, but we are optimistic that maybe we may find a way to at least probe the changes associated with serotonin level in the brain. So in summary, I think I convinced you that saturation and experiments can help us to identify tissue state, and that can be, we are now using it in clinic. It also is helpful in monitoring response. Also, a lot of things have to be done, especially in the cases of the tumor outside of the brain. There are a lot of issues associated with doing good CEST in prostate or breast or liver, etc. With a predicting response, this is still open. We have some preliminary data from the animals, but we are definitely not there yet. And last but not least, we still do not fully understand what is the nature of the changes of CEST contrast in the tissue. So with that, I would like to thank a lot of funders, CIHR, Terry Fox, Canadian Cancer Society, a lot of people who helped us out. Kim Desmond started this CEST project. Hatef Mehrabian joined in later. Right now, it's in the hands of Wilfred, Lidan Muri, and Rachel, who are doing a great job and moving all those sequences from the experimental Philips system to Siemens and GE and Philips as well. And we just started doing a real 3D saturation transfer experiments in humans as well. Thank you very much for your attention, and I am now open for any questions.
Thank you very much, Dr. Stanisz, for this great talk. And we now move, as you said, to the Q&A phase. I'd just like to remind everyone to please address your questions either using the chat, the Q&A box, or raise your hand. And while people are typing, I'll use the opportunity to ask you, you mentioned several CEST targets or compounds for the tumor prediction, amide, amine, and the RNOE, which from your experience was contributed the most to the prediction?
Okay, so it really depends. Let me put it this way. If we look at the monitoring the treatment, we found RNOE is probably the best. Amide is, and the reason it's not necessarily that it's the best compound to look at, but it's separated from everything else. It's on the right side of the spectrum. Amide is doing equally well. Amine is always very difficult to capture because it's very close to the resonance of water. I know that some people are using amine and amide ratio to assess pH. This is a very cool technique, but it's very prone to noise. So I would say RNOE first, then amide, but also MT is kind of, so it is interesting because we still, for example, do not know whether some of those groups are not, we are saying they are associated with proteins. They could be also associated with lipids as well. We don't know for sure.
Great, thank you very much. And another question. So you've mentioned a plethora of studies being done on many patients. What in your view is the main barrier for people to use routinely CEST in the clinic?
So mostly it's time, and it's a little bit of it. So our imaging protocol, and I have to say that right now almost every patient with glioma has it. It's about 45 minutes. It includes CEST, MT, and obviously gadolinium. We also need to measure T1 and B1 and B node mapping. So it's the time as an issue. And let me put it this way: in a brain, those patients are really, I think, desperate, and they want to have an MRI. We try to do it with patients with prostate, and they don't feel comfortable. Squeezing this time to something that is in order of 10-15 minutes, that's the first thing. We are working on it, and I think probably, you know, people right now hoping that artificial intelligence or machine learning will do the trick. Probably that's the way how we would go. We started the study, we will see. We can still pretty much, we collect a lot of set spectrum. We don't need that many data points, so we can squeeze this time.
Got it, thank you very much. And there's another question from Chris Farrar. Can you please unmute?
Hi, Greg, that was a great talk. Thanks a lot. I was wondering about the NOE signal and the stress. I mean, do you have any ideas on where that sensitivity?
I have no clue whatsoever.
Yeah, it's interesting that these aliphatic protons.
I have no idea, and we just started it we also do the treatment and with microbiome, and we can put those levels up again, but we have no idea what we actually do measure. As with the CEST as well, I mean, you can argue that this is GABA and whatever, but GABA not necessarily. Yes, we have a lot of CEST information on GABA, glutamate, and all those metabolites in vitro. How they behave in vivo, how they compete with the other molecules is unknown. So I don't know, and I don't know how to find it out, quite frankly.
Yeah, it's very intriguing. And I mean, you kind of touched on it, the whole issue of integrating it into the clinical workflow just because of the long time. And are you doing 3D CEST, or is this?
So we started doing 3D in about 3 months ago. That's how long it took us to convince Siemens that their sequences had to be modified. 2 years. But we also found out that in a brain metastasis, you can do 2 slices and just have a cross section of the tumor, and that's fine. 3D doesn't necessarily help you out. But I think in a lot of cases in which you would like to monitor the progress and whatever, yes, and we are doing right now 3D on Siemens.
Okay, yeah, because I mean, we've been doing some gliomas where they're treated with oncolytic virotherapy. But of course, you know, I'm not there telling them where to acquire the 1 slice. And so whether they get the right slice where they did the injection or not is kind of
that is the problem.
So
there is a problem.
It's kind of critical to try to get to 3D.
No, so we do have a 3D sequence. This is Siemens sequence that we helped sort of modify a little bit. We will have one for Philips as well. We can share it. It has a component sensing. It's actually a very good technique. It doesn't allow you to do a MT at the very large saturation pulses because of SAR issues.
Right.
But it is working great.
Okay, super. Great, thanks.
Thanks. And as I think that at this point we can conclude. And again, thank you so much for this great talk.
Thank you very much.
And we hope to see you next time in person.